ஹலோ.
Can you see my slides changing? You can? Okay.
Can you? Yeah.
I'll start. Good evening, everyone. Welcome to the masterclass on traumatic brain injury. So today I'm going to give a talk on the initial assessment and the management of traumatic brain injury. In traumatic brain injury, the essence is communication, and the communication should start from the pre-hospital itself, that is from the paramedic, and for the patient to arrive into the ER, and the patient will be seen by different specialities. So this requires a lot of communication until even the patient comes to the ICU. And so for this communication, a very easy way to communicate and for everybody to understand, we can use this MIST scale. So MIST is nothing but M for mode of injury, I for the injury sustained, the severity of that is the signs and symptoms of the injury, and what was the treatment if given earlier, if some first aid was done. So this makes sure that we don't miss out anything on the treatment which is given earlier, and helps in the continuity of care. So, traumatic brain injury, like any other, should be identified as a neuro-emergency first. So, once you identify it as a neuro-emergency, then what do? We have to go ahead with a emergency CT scan. So, but before you shift the patient to the CT room, we have to optimize the airway breathing and circulation, clear seizures, and see whether the patient is in a code brain situation. I'll be dealing with code brain situation a little later. Just do a focused neurological assessment, that is just the GCS pupils and a quick secondary survey, and basic labs like sugar, CBC, INR, blood grouping and type, and a brief history, which is the ample history, should be taken. And the 12-lead ECG can be taken even after the CT, but doing an ECG should not delay shifting the patient to CT if the patient does not have any cardiac problems or any breathlessness. So let's just go across, go to this case scenario. There's a 24-year-old female, and she's a software engineer. She was walking on the road and she was hit by a bike. She had a loss of consciousness for a few minutes on the scene, and she has event amnesia. She doesn't remember the events. So the first step is identify that it is a traumatic brain injury and this is a neuro emergency. Now, do we do a CT for all the patients? So it is said that there is a high risk of neurosurgical intervention if the GCS score is less than 15 at 2 hours after the injury, or if there is a suspected open or a depressed skull fracture, or any sign of Bisla skull fractures like a raccoon-eye or CSF otorrhea or rhinorrhea, and if the patient has more than 2 episodes of vomiting, and if there is an anticoagulant use, or if the age is more than 65 years, and there is only a moderate risk of brain injury if there is loss of consciousness for more than 5 minutes, amnesia before the after the impact, and dangerous mechanism of injuries. All this warrants a CT scan. Most often, even if it doesn't fit into this scenario, just to be on the safer side, we really do a CT scan. The second scenario would be a 46-year-old male has a road traffic accident. This patient has a loss of consciousness for 10 minutes, and then he regained consciousness. His vitals are stable. His GCS is E3, V4 and M6, but with equal pupils, but he's drowsy. So first step is to identify that it is a neuro emergency and shift the patient for an emergency CT scan. And before shifting to the CT scan, we have to optimize the ABCs. I'm repeating it just to emphasize it. Clear the seizures, clear the code brain situation, do only a focused neurological assessment, take only a brief history, do the labs, and 12-lead ECG if patient is having chest pain. If not, do it later. So on the CT scan, this patient is seen to have a EDH. So usually all the EDHs, if intervene very early, have a really good prognosis. Now, what anesthesia? Is it going to be TIVA or is it going to be inhalation? It will be dealt on with later in the later talks. And will this patient be requiring any post-op ventilation? Mostly no. Most often we're able to extubate these patients on table, but certain situations might warrant a post-op ventilation. Another case scenario, a 24-year-old male and his friend were going on a bike ride, and the bike hit against a car. So his friend, who was a pillion rider, died on spot, and this patient had loss of consciousness on scene. He vomited twice, and he also had seizures on the way, and he's having labored breathing. As you can see, this is a dangerous mechanism of injury. So this calls in for code trauma. So first is a mechanism. So in the mechanism, is it like a dangerous mechanism of injury? Next, we have to see for anatomical. If there are injuries to two or more body parts, if there are fracture of two or more long bones, if there is a spinal cord injury, amputation of a limb, or if there is any penetrating injury to the head, neck, torso, airway obstruction, all this comes under code trauma. And also you have to see the vitals, and if any of this is there, then code trauma has to be activated. So like I said before, first identify this as a neuro emergency and do a emergency CT scan. Before shifting to the radiology, please do the ER checklist. So in the primary survey, always do the airway with a C-spine control. Please don't think, always assume that the patient is having a spinal cord injury unless until proved otherwise by doing a CT spine or an X-ray using the Nexus criteria. C for the breathing and circulation with hemorrhage control, C for the GCS, and C for the temperature of the patient and the environment control. So these all things come under the primary survey. So in the primary survey, in the airway, clear the airway. There might be even some vomitus in the patient's airway. So put your finger inside and sweep out the vomitus if it is possible. Stabilization of the C-spine by putting a collar. And if intubation is required, like I said, cervical spine fractures, assume it is there until proved otherwise. So use MILS, that is manual inline stabilization maneuver for the intubation. So yeah, assume C-spine injury in all cases of TBI. Now coming to the breathing, it's very important to treat and prevent the hypoxemia. Our main aim is to maintain a saturation of 95% or more by giving supplemental oxygen. If intubation is required, the patient is having any paradoxical breathing, don't hesitate to intubate, but take all the precautions. Should we give PEEP or not? Usually the PEEP, how much we give, usually like 5 to 6, will not increase the ICP, so it can be safely given. Should you hyperventilate right now? So if it is a code brain situation, short periods of hyperventilation do help. Coming to the circulation, hypotension should be aggressively treated. So this is a traumatic brain injury, so it is a polytrauma situation. So assume that it is a hemorrhagic shock. So give isotonic crystalloids, avoid any sugar containing, dextrose containing fluids. And if any hemostatic resuscitation is required, then 1:1:1 should be given. That is 1 PRBC is to 1 FFP is to 1 platelet. If the patient is on any anticoagulants, then we have to immediately address it and try to reverse it. And if at all, when you intubate a patient, when you give propofol, that time the patient is bound to have some hypotension. So at that particular point, we can even use some drugs like noradrenaline or phenylephrine to combat the hypotension. So this is a lethal triad: hypotension, hypothermia, and acidosis. All three will make the patient's clinical scenario more detrimental. Now this graph is what I want to keep seeing further. So as you know, the cerebral perfusion pressure is nothing but the mean arterial pressure minus the intracranial pressure. So the figure, the graph A is showing the normal autoregulation, where the cerebral blood flow is maintained at a steady state even when the blood pressure keeps varying. But in traumatic brain injury, the autoregulation is impaired. It becomes like the graph B. That is, it becomes pressure passive. So if the cerebral perfusion pressure drops to 50 or below 50, or if it goes very high, it is pressure passive. That is, if the cerebral perfusion pressure falls, the cerebral blood flow also falls. So that means it is very prudent to maintain the mean arterial pressure at a higher level. At least we have to maintain the cerebral perfusion pressure at 60 millimeters of mercury, 60 to 70 millimeters of mercury. So before shifting to the radiology, in this particular case, the patient will be intubated, ventilation is started, and we have to resuscitate the patient. It is always important to assess the GCS once again after the resuscitation. Okay, so in particular this case, this patient has become even VT M2. So this means it is a code brain situation. So as you can see in this picture, one of the pupil of this patient is dilated. So what is coat brain? Coat brain is nothing but a clinical brain herniation. It means that there is an acute onset of pupillary dilatation. It can be unilateral or it can be bilateral, and posturing with Cushing's triad features like hypertension, bradycardia, and changes in the respiratory pattern. Now coming to this ICP volume curve, according to this curve, the brain can accommodate changes in the volume and still maintain a constant ICP. But at a certain point, even small changes in the volume causes a very high ICP. So this will cause clinical herniation. So how do we tackle this cold brain situation? The first is the tier 0, which is first adequately sedate the patient, because the more restless a patient is, the more the ICP is going to increase. The cerebral perfusion pressure should be maintained between 60 to 70 millimeters of mercury. If the patient is having fever, do treat it. And steroids have got no role in the cold brain situation. Secure the airway. If intubation is required, it has to be done. And short duration of hyperventilation is definitely beneficial. Osmotherapy can be given with mannitol, and 3% saline can be started, and do a CT. Meanwhile, if hypertonic saline bolus or infusion is required, started. And as a last resort, propofol bolus and infusion can also be started. And if the patient needs a surgical decompression, then we have to go ahead with it. Or if surgery is not an option, then we have to give the option of maximum medical management, which would be even hypothermia and anesthesia. Now, coming to anti-epileptic drugs, should we give it or should we not give? So, if a seizure activity was witnessed, then there is no question we have to give the anti-epileptic drugs. But if the patient has just a depressed level of consciousness, or the patient did not have any seizure, or if the CT brain is abnormal, then in order to prevent the early post-traumatic seizures, we do give anti-epileptic drugs for 7 days. So we can give either phenytoin 20 milligram per kg IV, or fosphenytoin, or levetiracetam is also an option. So what are we dealing with? It is mainly the primary injury. The primary injury, we cannot do anything about it because it has already happened at the site of the injury. It is mainly because of the crushing and the shearing forces which causes the EDH, SDH, or the skull fractures. The secondary injuries are the one which we can try to do something about. The secondary injuries, they start within seconds after the traumatic brain injury, and they continue to go on for hours and even for days. So it is mainly because of the hypoxia, the ischemia, the cerebral edema, which all happens because of the excitotoxicity which happens to the brain. So it's very important to prevent any hypoxemia. We have to maintain a saturation, try to maintain a saturation of more than 95, avoid hypotension, maintain a cerebral perfusion pressure of 60 to 70 millimeters of mercury, clear seizures. If there is seizures, then give phenytoin or fosphenytoin. If there is raised ICP, we have to go through the tiered management. If the patient is taking any anticoagulants or anything like that, we have to reverse it and treat the coagulopathy as well. So prevention management of secondary injury is the main focus of management, because this is the main determinant of the clinical outcome, because the changes occur on both microscopic as well as the macroscopic levels. All these treatment strategies should begin immediately after the trauma, and it has to be continued, and it can be prevented, but if not controlled. It cannot be prevented, but can be controlled. So in the primary survey, it's very important to maintain the temperature. Hyperthermia, definitely no, we should try to maintain the patient normothermic, but hypothermia is also very, very deleterious, mainly because of this lethal triad, which is not good for the patient. Now, what brief history? This is the ample history, which stands for allergies, medications, past illness, the last meal the patient has taken, and the events in sequence. This is all that is enough at the time when the patient comes to us. Usually in our hospital, if there is a polytrauma, we usually do the pan-CT. Pan-CT includes a CT brain, CT C-spine, chest, CT abdomen, pelvis, and the whole spine. If at all a contra-CT is required for the abdomen, we really do not need to wait for the creatinine report at this point. On the CT imaging, these are the few findings we can see. It can be an EDH, SDH, contusion, diffuse axonal injury, diffuse edema, or maybe even fractures. So these are the few images of skull fractures. They can be linear, depressed. They can be skull-based fractures. These are CT images of EDH, contusions, diffuse axonal injuries, subdural hematomas, SAH, and diffuse cerebral edema. So to grade the traumatic brain injury, we usually use the Marshall grading. A patient who has underwent a surgery comes under grade 6. So sometimes on the CT brain, we'll be able to see some mixed densities. So that means there is an active bleeding going on, and so we might have to do an interval CT also later. Sometimes the patient comes, the GCS may be preserved, and there may be only a small contusion, but contusions tend to evolve. So definitely an interval CT has to be done. Like you can see in this case, on the left side, there's only a small contusion, but on day 2 when we did the repeat CT, there are even in the opposite side there are contusions, and the present contusion has also evolved and become bigger. So what are the CT red flags? So midline shifts more than 5 millimeters, or just a midline shift at all, and then efface cisterns, uncal herniation, subfalcine herniation, transtentorial herniation, and mixed densities mean an active bleeder. All these are the red flags. So these are some images showing subfalcine herniation. As you can see, the fox is moved to the opposite side. Uncus is a part of the temporal lobe. So you can see that the ipsilateral temporal lobe has got effaced, and the uncus is pushing medially. There's a transtentorial herniation. And this is the mass effect, where you can see that the midline has been completely shifted. So the focus of management. So if a patient comes like this, such a gross midline shift, then obviously our focus of management would be to take the patient very fast to the OT and get the clot out. So again, even during the transport and even the OT, we have to avoid hypoxemia, avoid hypotension, seizure prevention and treatment, and we have to treat the elevated ICP and correct coagulopathy. So this is the decompressive craniectomy which was done for this patient, and the hematoma has been evacuated. So ICP monitoring is done mainly for patients with a GCS of between 3 to 8 and an abnormal CT scan. And if the patient's GCS is 3 to 8 but a normal CT, but if the patient's age is more than 40 years, the patient is having motor posturing, and if the SBP, systolic blood pressure, is less than 90 millimeters of mercury, or if the GCS is 9 to 15 but the CT shows a mass lesion, efface cisterns, or a brain shift of more than 5 millimeters, a post craniotomy, and a neurological examination that cannot be followed. So this has been already dealt with. So if at all there is a refractory ICP, then what can be done? It is a tier 3 measures. We can go ahead with a barbiturate coma, moderate hypothermia, hyperventilation for a short term, guided with jugular venous oximetry, and cerebral perfusion pressure manipulation, that is induced hypertension, in order to decrease the ICP. Post-operative deterioration is it is one of the common things. It's not very uncommon. So this patient had, after the surgery, he had a pin side EDH, and it was in the opposite side. So again, that also had to be evacuated. Now coming to the devastating traumatic brain injury. Uh, this is different from severe traumatic brain injury. So this case scenario, a 16-year-old young boy, he had accident by a two-wheeler. He was found unconscious on the roadside. He had vomiting, he had seizures. He was taken to the nearby hospital. He was intubated, ventilation was started, and hemodynamics was stable, no other major injuries. And on examination, the patient was even VTM2, pupils were dilated 6 millimeters bilateral, and it was not reacting. Cough reflex was positive, spontaneous breathing effort was positive. And like you can see over here, it's like a diffuse edema is present, and there is a bleed on the right side. So this is called as a devastating brain injury. Nothing can be done for these patients except for a tier 3 treatment. A 1 year 6-month-old child fell from a balcony of the first floor while playing. Loss of consciousness. He had loss of consciousness, but he was crying on the way to the hospital. CT was done and referred. This was a TCT when we saw. There was almost like a reversal of flow, but pediatric patients may tend to surprise us, like this patient did. We did a DC posterior fossa decompressive craniectomy for this patient, and again we had to do a bifrontal parietal decompressive craniectomy, and then the patient improved to M3, and then now the child is doing really well. So, but if it's an adult patient, the scenario would be totally different. Devastating traumatic brain injury is almost always non-salvageable, but in a pediatric patient, we might have to. We should not give up. And this is very important to do all this in an integrated neuro care, mainly for better outcomes. Yeah, thank you.
Thank you, Dr. Sindhu. I request Dr. Swati to continue the talk on anesthetic management of TBI.
Thank you, Dr. Matangi. I'll just share my slides here. I hope I'm audible and the slides are visible as well.
Yes, ma'am,
Uh,
you're audible and slides are visible, ma'am.
Right. So, Dr. Sindhu has very aptly and appropriately and comprehensively covered the initial assessment and management part. So, I believe half of my work is done because we get a very nicely evaluated and managed patient. And I've been greetings from my institute. So, the role of anesthesiologist while managing a patient with TBI ranges from emergency department management to the operative if he is being taken for the surgery and extends to the intensive care. So, as told earlier, the pathophysiology of traumatic brain injury, we have a primary brain injury and a secondary brain injury. And the primary brain injury is the one which occurs at the time of trauma. So, there are like many mechanisms: direct impact, penetrating injuries, rapid accelerations, blast waves, such that the external mechanical forces they get transferred to the intracranial contents, and we can get either isolated injuries or combination of these injuries, which can range from just skull fractures to epidural hematomas, subdural hematomas, intracranial hemorrhage, contusions, SAH, and diffuse axonal injury. So the management, the surgical management or conservative, is totally depends on the extent of injury, combinations, and patient's condition, and if there is any deterioration. But the secondary brain injury is where, as previously said, is the main focus of management because the primary brain injury is there, it is irreversible and is being managed. But the cascade of molecular injuries, which are sequelae at the time of primary brain injury, they result in neuronal cell death, cerebral edema, and increased ICP, and hence they exacerbate the brain injury. So it's this is secondary brain injury is bound to happen, but with our well-tailored management, we can decrease the impact of secondary brain injury and improve outcomes. So, the anesthesia management, this will be the overview, the range from pre-anesthetic evaluation, intraoperative, and post-operative management. The pre-anesthetic evaluation should be as comprehensive as possible, but keeping in mind the time permissible. And usually, these patients are already evaluated as with the ample history provided by the ED department assessment. Still, we should reassess the patients with minimum Glasgow Coma scale or more recently used full outline of unresponsiveness score, which is the 4 score, which also takes into account the brainstem reflexes. Now, assessment of the clinical severity of TBI helps us estimate the degree of impaired physiology, like the autoregulation and other parameters. It helps us determine the urgency of surgery, predicts the risk for complications both intraoperatively and postoperatively, and prognosticate the patient. Laboratory evaluations still are guided and continuously done, and we might or might not wait for the results to get back. But minimum we can have is send for a blood gases and coagulation profile. If lots of blood loss is expected due to secondary injuries, extracranial injuries, we should keep type and screen or cross match as the case might be. And radiological evaluation CT would have already been done, and also we can do radiology pertaining to other extracranial injuries like CT thorax or abdomen, or just a fast scan with to rule out the abdominal or chest injuries. But time is important, so we should just evaluate based on the time available. Now, this is the most important slide in my view because we have to fix our goals of anesthetic management. We should facilitate early cerebral decompression in patients who are having expanding intracranial hematoma, treat ICP, and many times the ICP monitor and management is already underway in the ED department or from the ICU where the patient is taken into the OR. So that can be continued. The monitoring can be continued during the transport and surgery. Mostly the EVTs are placed, so they can be both diagnostic for ICP measurement as well as for the management of raised ICP. We should maintain cerebral perfusion pressure and avoid secondary insults like hypoxemia, hypotension, hyper and hypocarbia, hypo and hyperglycemia, seizures, and coagulopathy. And wherever possible, we should facilitate early postoperative neurological evaluation. The intraoperative monitoring includes the standard ASA monitors, the invasive blood pressure monitor, ICP monitor if already in place that can be used. EEG monitoring helps us know about the seizures, and these are can also be used for extracranial surgeries. Um, but we should not wait for placement of invasive arterial lines that could delay institution of decompressive craniectomy. And we could think about advanced neuromonitoring depending on patient's condition. If it's like refractory raised ICP which is refractory to all the mechanisms, we can have a jugular venous oximetry already in place, or brain tissue oxygen tension monitoring so as to titrate the hyperventilation which is required. As far as venous access is concerned, we should not waste time taking a central venous catheter if we already have a good peripheral IV access. And usually CVC central venous catheter can be taken after the decompression is done, before shifting the patient back to ICU for vasopressor institution or just for the venous access. Now the anesthetic agents, the technique usually doesn't make much of difference in the patients, but so it also depends on the degree of increase in ICP. So the choice is usually based so as to maintain the hemodynamic stability, preserve the cerebral perfusion, avoid increases in ICP, and to avoid and treat secondary brain injury. So, depending on the patient's hemodynamic status, we can either use propofol or etomidate for induction. Nitrous oxide, because there could be coexisting pneumocephalus or pneumothorax, it is better avoided in patients with TBI. We can use opioids because when used as a component for TIVA or with propofol, it has minimal effect on cerebral physiology. Paracetamol or acetaminophen can be used for the postoperative pain. For neuromuscular blockade, succinylcholine can be used, and if we are concerned about the raised ICP, we can use defasciculating dose of non-depolarizing agents, because it is mainly due to the cerebral arousal due to the fasciculations that there is a transient increase in ICP due to succinylcholine. Now, the main emphasis is on the maintenance of anesthesia, wherein the question comes for TIVA versus inhalation agents. As far as the other routine elective neurosurgical procedures are concerned, the results of all the researches are equivocal about TIVA and inhalation, and any of which can be used provided the inhalation agents are used in less than 1 MAC concentration. But the scenario could be a bit different with TBI patients, because here the ICP is already increased, and we do not want to further increase the secondary insult. So in these cases, TIVA with propofol is a better choice because it decreases the cerebral blood flow and hence results in decrease in ICP. And so clear choice with the increased ICP with the angry brain, where brain relaxation is important. The TIVA should be a clear choice, although the level of evidence is not that recommendation, but it is still followed. And then there are some adjuncts used, dexmedetomidine and ketamine, which deserve a bit more discussion. So dexmedetomidine, it has been used mainly for the sedation in ICU, and probably this will be dealt with in the upcoming talk. But most of the use is in the sedation in the ICUs, and much lesser use in the operating rooms. Um, it has been observed that in healthy volunteers, the metabolic rate and blood flow coupling is preserved with dexmedetomidine. But since dexmedetomidine is a cerebral vasoconstrictor, there is a concern for regional cerebral ischemia or compromised flow metabolism coupling in TBI patients. But there is a limited evidence, but experts say that it can be used as far as the hypotension is appropriately managed. Coming to the ketamine, there was always a concern regarding the rise in ICP with ketamine, but recently, not recently actually, over the past decade, it has made a comeback and being used in traumatic brain injuries or pathological brains as well, and it has been rather found to have no or favorable effect on ICP. So we have this narrative reviews from very recent in 2022, and another article from Journal of Critical Care in 2014, where ketamine was used and was found to have good effect. So there is in all the in many of the studies there was no pathological increase in ICP was found. Rather, there was decrease in ICP values for short time and for short time use, and there is decline in ICP in pediatric population was observed, and CPP, the cerebral perfusion pressure, was found to increase in the patients without any adverse effects. So this is rather preferred for airway management also in patients presenting with traumatic brain injury. So we should not just shun it away and use it. The recommended dose is 10 milligrams per hour. Airway management has been in detail covered by Dr. Sindhu in the previous talk. So we should be aware of cervical spine injury, and the patient should be deemed to have a cervical spine injury unless proved otherwise. And we can use video laryngoscope, fiber optic bronchoscopy with manual inline stabilization. There is a doubt of if there is a doubt about the fasting status or there is a delayed gastric emptying due to trauma. A rapid sequence induction and intubation can be used with succinylcholine or rocuronium. And as discussed further, succinylcholine, if there is a risk of transient increase of ICP, defasciculating dose of non-depotorizing agents can be used. Coming to oxygenation and ventilation, so the target is for arterial oxygen pressure is more than 60, and we should also be avoiding hyperoxia, and it should be limited to less than 200 millimeters of mercury. Hyperoxia, because it can lead to hyperoxic cerebral vasoconstriction, and then there is also a risk for oxygen free radicals. So it is better to avoid hyperoxia, although some studies have shown a favorable outcome with hyperoxia, but this is what the recommendation says. And hyperventilation can be used in selected patients, usually 30 to 35 millimeters levels of partial pressure of CO2 for limited duration. Otherwise, 35 to 40 is the thing if there is enough brain relaxation. However, if some patients, due to raised ICP, which is refractory and they require prolonged hyperventilation, this should be done under the guidance of jugular venous oximetry or the measurement of oxygen tension in brain tissue or cerebral blood flow as measured with TCD. So red flags are hypoxemia, hyperoxia, hypercarbia, and hypocarbia. So all our ventilatory strategies should be aimed to avoid these red flags or treat these red flags. Hemodynamic management is of paramount importance so as to avoid the secondary brain injuries. The patients they have with TBI have impaired or non-existent autoregulation of cerebral blood flow, and they are known to be pressure passive. So, if there is an increase in mean arterial pressure, there could be secondary hemorrhage, edema, and further increase in ICP. And decrease in mean arterial pressure can lead to hypoperfusion and ischemia. So the goals, as mentioned in the Brain Trauma Foundation guidelines in 2016, are ICP should be less than 22 millimeters of mercury, cerebral perfusion pressure 60 to 70, and there should be avoidance of getting the cerebral perfusion pressure more than 70, and systolic blood pressure at least more than 100 to 110, depending on the patient's age and underlying pathologies. Intraoperative hypertension occurs quite commonly during the procedures, which is as common as 32 to 65%. The risk factors could be polytrauma with other injuries in the abdomen or thorax, low GCS score at presentation, preoperative tachycardia and hypertension, delayed surgery, and multiple lesions on the CT head. So, sudden hypertension can occur after removal of bone flap due to sudden decrease in ICP. And if the duration of intraoperative hypertension is prolonged, there is association with unfavorable outcomes at 6 months. So the hemodynamic goals can be achieved with fluids and administration of vasoactive medications. So the preferred fluids are non-glucose containing isotonic crystalloid solutions. Colloids are not generally preferred because they may increase ICP in patients with altered blood-brain barriers, as in patients with TBI. In the SAFE study, where the saline was compared to albumin, there was increase. It was found that there's an increase in death among patients with TBI who received albumin. And in addition to this, the hydroxyethyl starches can also precipitate coagulopathy or aggravate them. And osmotic therapy can be instituted, as previously mentioned, with hypertonic saline and mannitol with proper ICP monitoring and taking care of the hypovolemic status of the patient and to avoid hypotension. The vasopressor choice is determined by the underlying or TBI-induced cardiac dysfunction. There are no clear recommendations from Brain Trauma Foundation guidelines. Many of the agents have been studied. Phenylephrine is still the most commonly used. Ephedrine has favorable outcomes, favorable results with cerebral oxygenation, but ephedrine infusions are not yet very commonly used. And noradrenaline and dopamine have been compared, where noradrenaline has been found to have a better cerebral oxygenation, and vasodilators like nitroprusside, etc., they increase cerebral blood flow and should be used with extreme caution or avoided in totality. So this is a very interesting article and very informative one from JNA in 2020, which gives a complete narrative review of vasopressors and the effect of vasopressors on cerebral circulation and oxygenation. And I highly recommend reading this article because this topic is in itself a complete 1 hour subject. Coming to blood transfusion, 2014 study published in JAMA demonstrated that neither the administration of erythropoietin or nor maintaining hemoglobin, liberal hemoglobin levels of 10 grams per deciliter improved neurological outcomes at 6 months. So a transfusion threshold of 10 gram per deciliter was associated with higher incidence of adverse events. So blood transfusion, the decision for blood transfusion should be based on ongoing bleeding, clinical status, and patient comorbidities. Coming to the further aspects of management intraoperatively, we should achieve the target of normothermia. Induced hypothermia, which is mild hypothermia, should be reserved for patients with elevated ICP, which is refractory to other therapies. And so should the barbiturate coma should be reserved for these patients, and not routine brain protective strategies in terms of barbiturates or extra doses of propofol should be used. Glucose levels recommended are 80 to 180 milligrams per deciliter, and tighter control is not recommended. Anti-seizure medications for prophylaxis or for actual seizure management is recommended for post-traumatic patients. The one recommended by the Brain Trauma Foundation is phenytoin, although phosphenitoin and recently levetiracetam are also commonly used for their better side effect profile. And routine administration of glucocorticoids is not recommended, and it is a level 1 recommendation with available evidence. Coagulopathy is an important issue because TBI, it induces systemic release of tissue factors and a release of brain phospholipids into the circulation. So there is inappropriate intravascular coagulation and consumptive coagulopathy. So our goal is to maintain an INR of less than 1.4. If we encounter a coagulopathy with INR more than 1.5, we can give fresh frozen plasma or prothrombin complex concentrates, and with or without vitamin K. And trauma-induced platelet dysfunction is also common, although there is still no clear guidelines on platelet transfusion for prophylaxis or for management. And in this study, it was recommended that prothrombin complex concentrate should be used with FFPs for management of coagulopathies in patients not taking warfarin. And we should also address brain relaxation with the techniques which we used in other neurosurgical patients, like cerebral CSF drainage, use of osmotic agents, hyperventilation till the permissible levels, augmentation of anesthesia, venous drainage by head up, and mild controlled hypertension if autoregulation is present, which is usually not the case with TBI patients. So during recovery, the patients with isolated skull fractures or EDH with good GCS score, higher GCS scores preoperatively can be extubated in OT. Other patients with severe TBI or polytrauma should receive elective ventilation ICU. They should have a postoperative CT scan. There should be a continuity of care from ED through OR into the ICU, and monitoring should continue during transport. At handoff, there should be clear communication and use of checklist is recommended. So, to summarize, the TBI presents a complex scenario and multidisciplinary approach is important. Should avoid secondary insults, maintain the continuity of care, and emphasize integrated decision based on current evidence and multimodal monitoring. These are my references and very important and informative articles on up to date, and of course the guidelines which we are all following. Thank you so much.
Thank you, ma'am. Thank you for this wonderful presentation on a comprehensive intraoperative management of traumatic brain injury. I would like to now invite Dr. Sharmishtha to talk about the ICU management of traumatic brain injury.
Yeah, thank you, Dr. Matangi. Just sharing my slides.
Yeah, Dr.
Good
Sharmishtha, your
evening.
slides are visible.
Slides are visible? Okay. Okay.
Yes,
Good
yes.
evening, all. Now the initial assessment part and the anesthetic management part has been dealt with. So 50% of the work of the ICU neurointensivist has been done. Starting with the ICU management, I will cover my presentation under the following headings of introduction, slight brief on pathophysiology, principles of ICU care, monitoring, respiratory care, cardiovascular system care, taking care of the nutrition and glucose control, and finally, general care. So, starting with the introduction, TBI moderate to severe is the one which generally requires a neuro ICU care. It requires a multidisciplinary team approach with major goals to measures to prevent the secondary brain injury, optimize the conditions for recovery of the patient and early rehabilitation, and provide an individualized and tailored treatment approach as per the patient. Briefly, primary injury is the one where damage to the direct brain parenchyma has occurred, either to the tissue or vessels, while secondary brain injury results from systemic insults to the brain. While the patient comes to ICU, we are primarily dealing with these secondary brain injuries, which can result either from hypotension or hypertension, hypoxia, PaO2 less than 60 millimeters of mercury, hypo or hypercapnia, anemia, hypoglycemia or hyperglycemia, hypo or hyperthermia, electrolyte disorders, epileptic seizures, spreading depolarization, which are adding to the energy expenditure, producing anaerobic metabolism, leading to energy substrate depletion, and ultimately resulting in a worse outcome. So, what are the principles of care in the ICU? Firstly, stabilization of the patient, both hemodynamically and neurologically, prevention of any further intracranial hypertension, maintenance of an adequate and stable cerebral perfusion pressure, avoidance of systemic secondary brain insults, and optimization of cerebral hemodynamics and oxygenation. Starting with monitoring. So there are two parts of monitoring, the general monitoring of the patient and specific neurologic monitoring. So what should we monitor generally in a patient in the neuro ICU with a TBI? The primary monitors which we should be using are ECG to monitor the cardiovascular system, pulse oximetry, capnography for early assessment of hypo or hypercapnia, arterial blood pressure for beat-to-beat monitoring of blood pressure to know early for any incidences of hypo or hypertension, central venous pressure, systemic temperature monitoring, urine output monitoring, and regular interval monitoring of arterial blood gases. For neuro monitoring, we should be monitoring the intracranial pressure, Transcranial Doppler can be used for TBI patients, jugular bulb venous oxygen saturation, brain tissue oxygen tension, cerebral microdialysis, and EEG. Firstly, every patient in neuro ICU should receive a good clinical assessment, which involves neurological clinical examination for early identification of any need for surgical intervention. This includes regular GCS assessment of the patient, preferably hourly to 2-hourly, investigations of the pupillary diameter and their reactivity to light, again, preferably done hourly or 2-hourly. We should be using interruption of sedation, that is the wake-up test, at least once a day to measure the GCS of the patient. But it should be kept in mind that interruption of sedation can produce arterial hypertension, fighting the ventilator in the patient, increased oxygen consumption, and may also result in transient rise in ICP. Now, starting with the ICP monitoring, when is it indicated? It is indicated according to the Brain Trauma Foundation guidelines if the GCS is between 3 to 8 and an abnormal CT. With a GCS of 3 to 8 but a normal CT and any of two of the following, that is age over 40 or motor posturing, either unilateral or bilateral, hypotension with a systolic blood pressure under 90 millimeters of mercury, and an increased intracranial pressure of 22 millimeters mercury is the threshold for treatment. What are the benefits which we achieve by using ICP monitoring? Earlier detection of any expanding intracranial mass lesion, guidance of the medical therapy as well as surgical therapy, avoidance of any indiscriminate use of therapies to control ICP, that is when to stop using these therapies, drainage of extra CSF with reduction of ICP if we are using invasive modalities like EVD, improvement of the cerebral perfusion pressure, and also helps us in determining the prognosis of the patient. Second modality which is used in neuro ICU is jugular bulb venous oxygen saturation. It is an indicator of both the cerebral oxygenation as well as cerebral metabolism by providing a ratio between the cerebral blood flow and CMRO2. We can use monitoring of jugular bulb venous oxygen saturation either continuously using a fiber optic catheter or intermittently via repeated blood sampling. The average normal SGVO2 values range from 55 to 71% with an average normal of 62%. A sustained desaturation of less than 50% is considered as the threshold for cerebral ischemia and should be taken as the benchmark for treatment. The sustained desaturation of SGVO2 values has also been seen to be associated with poor outcomes and has been found to be an independent risk factor for poor prognosis. Another modality which we use in TBI patients is brain tissue oxygen tension in the ICU. While SGVO2 was a monitor for global cerebral oxygenation, PbTO2 provides a focal cerebral oxygenation value. It helps in monitoring the oxygenation of the critically perfused brain tissue, that is the tissue which is next to the injury. The normal values range between 35 to 50, and a value of less than 15 is considered as a threshold for treating focal cerebral ischemia. There was an article published in Criticare Medicine in 2017, which was a boost 2 trial rather, which said that treatment of secondary injury occurring after severe TBI based on PbTO2 and ICP values was consistent with reduced mortality and increased proportion of patients with good recovery compared to ICP only management. Another modality which can be used is cerebral microdialysis, which we use commonly in neuro ICUs, where we insert the catheter into the susceptible brain tissue and measure the biochemical changes occurring in the area of brain which is most vulnerable to secondary insults. Cerebral hypoxia or ischemia, which may occur during the post-operative period in the ICU, can result in significant increase in lactate pyruvate ratio, whereas a lactate pyruvate ratio of more than 20 to 25 is considered as a threshold for cerebral ischemia and should be considered for adding interventions into treating these TBI patients. This has been found to be associated again with poor outcome in severe TBI patients. Transcranial Doppler ultrasonography provides us with a non-invasive alternative technique for measuring the cerebral blood flow velocity. Thus, it is a technique for assessment of ICP and CPP. It is a clinically useful tool in diagnosing of complications like vasospasm, critical elevations of ICP and decreases in CPP, carotid dissection, and cerebral circulation arrest, that is brain death. It also helps us in predicting post-traumatic vasospasm prior to any clinical manifestation, thus giving us a crucial time window to intervene early and provide a better prognosis to the patient. Electrophysiological monitoring in the form of EEG is another clinically useful tool which can help us in monitoring the depth of coma, detecting any non-convulsive or subclinical seizures or seizure activity in pharmacologically paralyzed patients, and also helps us in diagnosing brain death. Continuous EEG is suggested for diagnosing post-traumatic seizures. Moving on to the care of other systems. While the care of the primary neurological system is very important, it is of paramount, the other systems become important because they help us in preventing deleterious effects onto the brain as a result of secondary brain injury. So respiratory care provides us with airway protective reflexes which are blunted in TBI patients, especially in moderate and severe TBI patients. They are at high risk of aspiration and other respiratory complications like pneumonia and ARDS. These complications can also be directly related to extracranial injuries, that is direct thoracic injuries in the form of pneumothorax, hemothorax, or lung contusions. Associated cervical spine injury is another reason for these patients to require ventilatory support. There is no specific ventilatory strategy per se established till date for taking care of TBI patients in the ICU. There should be individualized ventilation strategies in place, that is, use what is good for your patient. Controlled mode, or either in the form of volume control or pressure control, can be the mode which can be used during the initial phase as soon as we receive the patient in ICU. We can shift on to assisted mode or pressure support mode as our patient shows clinical improvement. Hyperventilation is a very important thing which should be used judicially only for treatment of refractory intracranial hypertension, as any hypocapnia or hypocarbia can result in cerebral ischemia. The target goal should be maintaining normocapnia, that is a PaCO2 of 35 millimeters of mercury. Hyper and hypo both should be avoided as they can be associated with cerebral ischemia. TBI patients with one or more failed weaning trials should be considered for tracheostomy, as early tracheostomy can help us in maintaining oral hygiene, preventing ventilator-associated pneumonias, and thus early rehabilitation of these patients. Circulatory system care is an important part, as cardiac dysfunction is found in approximately 8 to 33% of patients suffering from moderate to severe TBI. It is associated with increased risk of cardiovascular disturbances. It can manifest as ST T wave and QT prolongations on the ECG. There can be reduced ventricular function, regional wall motion abnormality. Although there is no specific therapy available, non-pharmacological methods like avoiding any external stimuli, maintaining hydration, correcting electrolyte imbalance can be used. And pharmacological strategies include use of opioids and beta blocker for paroxysmal sympathetic hyperactivity. At all circumstances, incidences of hypo or hypertension should be avoided as they can compromise cerebral perfusion pressure. Hypotension in such cases has been defined as a systolic blood pressure of less than 90 or a mean arterial pressure of less than 65, and it has been seen as an independent predictor for secondary systemic brain insult. The common causes can be intravascular volume depletion due to hemorrhage resulting from other organ injury, extracranial injuries, as it is a polytrauma situation, polyuria secondary to diabetes insipidus occurring as a result of brain injury, or spinal cord injury associated with spinal shock. Hypertension similarly with a systolic blood pressure of more than 160 or a mean arterial pressure of more than 110 millimeters of mercury should be avoided as it can aggravate brain edema and ischemia. All measures should be taken to achieve normotension or normal CPP. Normal physiological raise in blood pressure can be tolerated as it can be a mechanism of the body to compensate for the raised ICP. Induced hypertension, however, should not be considered for patients, especially without ICP monitoring. Aggressive treatment of blood pressure in patients with raised ICP can sometimes worsen morbidity and even result in death. Thus, our target should be to maintain the cerebral perfusion pressure between 60 to 70 millimeters of mercury. We can use intravenous fluid and vasopressors for resuscitation. The ideal fluid for TBI patients is still controversial. There is no ideal fluid at present. What has been recommended is to avoid using hypotonic fluids, as it can prevent volume overload and result in cerebral edema. Nutrition and glucose control form a very important part in management of TBI patients in the ICU, as it has been seen that providing early nutrition to these patients has beneficial effects, has good recovery and early rehabilitation, results in reduction in mortality, and reduces overall poor outcome and infection rates. Enteral feeding is always preferred in TBI patients, as it provides us with the advantages of preserving the GIT functions, immunological gut barrier is preserved, and it preserves the mucosal integrity. TBI patients are seen to have gastric delays, which can be due to increased intracranial pressure and also due to opioids, which are usually used for sedation in ICU. Prokinetic agents like metoclopramide usually improve this intolerance in patients and can be added to their management. Indirect calorimetry or Harris-Benedict's equation or weight-based formulas, that is 25 to 30 calorie per kg body weight per day, can be used to calculate the caloric requirements in these patients and thus provide the patients with early enteral feeding. Stress-induced hyperglycemia is very common in traumatic brain injury patients, and this hyperglycemia is again a cause of secondary brain injury. So hyperglycemia, how it produces secondary brain injury is by increasing the release of pro-inflammatory cytokines. As it is, trauma is a state in which pro-inflammatory cytokines have been released in the circulation. Associated hyperglycemia in a patient further increases the release of these cytokines, which results in secondary brain injury or neuronal injury. So blood glucose levels should be regulated, but tight limits, that is a tight control maintaining between 81 to 108 is not recommended. It is highly controversial, as any incidences of hypoglycemia are further detrimental to the damaged neurons. And a tight maintenance of blood glucose control is associated with increased hypoglycemic incidences. So the target blood glucose is not defined per se, but a moderate approach to glucose control, that is maintaining the blood glucose between 120 to 180 milligram per deciliter, is the preferred modality during ICU care. Moving on to the sedation and analgesia part, which forms a very important part in the management of patients in the neuro ICU, especially TBI patients, as these patients require sedation at multiple levels. They require sedation so as to take care of their ventilatory requirements. They should not fight with the ventilator. They require sedation so that adequate nursing care can be provided, adequate dressing, but neurological assessment should also not be hampered. So we should ensure that the patient is comfortable, and we should be able to relieve the pain of these patients. Sedation and analgesia provided limits any elevations of ICP, any discomfort to the patient, any discomfort arising due to cough or pain, decreased oxygen consumption, and decreased CO2 production. So TBI, but the downside is that the TBI patients need daily neurological assessments, and these assessments can be frequently confounded by use of sedation. So we require an ideal sedative or analgesic, which should have a rapid onset and offset, should be easily titratable, and should have a predictable clearance. There should be no or minimum effect on ICP and CMRO2, and also the cardiovascular system. So the most common drugs which we use in our ICUs are opioids in the form of fentanyl, propofol, benzodiazepines in the form of midazolam and lorazepam, and dexmedetomidine. Starting with propofol is usually the hypnotic of choice in patients with an acute neurological insult, as it is easily titrable, rapidly reversible once discontinued, has a predictable sedation, and allows for periodic neurological evaluation, but it should be avoided in hypotensive or hypovolemic patients and has a downside of causing propofol infusion syndrome. Benzodiazepines, on the other hand, are recommended as continuous infusion or intermittent boluses. They provide sedation, amnesia, and anticonvulsive effect, but the risk factors for accumulation and oversedation should be considered, like prolonged infusion or high dose requirement, presence of renal or hepatic failure, and old age. Neuromuscular blocking agents, on the other hand, routinely are not recommended to be used in patients with TBI. Although they help in reducing ICP, they should be considered only as second line therapy for refractory intracranial hypertension, as they are usually associated with increased risk of pneumonia and ICU length of stay, and also with neuromuscular complications. Dexmedetomidine has a good sedative action, allows good neurological assessment, but can result in decrease in hemodynamic parameters transiently. So there is no one agent which can be used, as there is no ideal agent available. A combination of these agents can be used, or they can be used as intermittent boluses or continuous sedation. Moving on to the seizure prophylaxis in ICU, it should be considered for treating the early post-traumatic seizures, that is the seizures occurring within the 7 days. Phenytoin is recommended for early post-traumatic seizures, and current guidelines do not recommend any anti-seizure prophylaxis for late post-traumatic seizures. Now the question comes whether levetiracetam or phenytoin. So both of them are comparable in efficacy, mortality rate, and adverse reactions, but there is no complete evidence, or there is insufficient evidence to recommend one levetiracetam over the other, that is phenytoin. Now moving on to stress ulcer prophylaxis. Now stress ulcers also form because of imbalance between mucosal protection and gastric acid production. There is increased acid secretion due to the stress triggered vagal stimulation, impaired mucosal production because the microcirculation is impaired. So two drugs which are found to reduce the incidence which can be used are proton pump inhibitors and H2 receptor antagonists. Deep venous thrombus prophylaxis should be used. Approximately 20% of all TBI patients have shown features of venous thromboembolism. Old age, obesity, and severity of TBI all increase the risk of venous thromboembolism in TBI patients. Patients receiving pharmacological prophylaxis have found to have a lower incidence of thromboembolism and a lower incidence of worsening hemorrhage. It is also safe in patients in which we have used an invasive ICP monitor. Pharmacological DVT prophylaxis and combining it with mechanical prophylaxis are recommended, especially if the injury is stable. Mechanical prophylaxis may not always be possible because the patient may have associated limb injuries as well. Now moving on to hypothermia, which can be defined as the temperature from 32 to 34 degrees Celsius. It helps in reducing the cerebral metabolic rate, preserves tissues in the face of metabolic challenge, and decreases the ICP. But there is no good evidence to support prophylactic hypothermia, although it can be, however, used as a part of multimodality approach. But we should keep in mind that any episodes of fever should definitely be aggressively managed in patients of severe TBI. Steroids are not recommended by Brain Trauma Foundation guidelines at all to reduce ICP. CRASH trial has shown unfavorable outcomes in severe TBI patients in whom methylprednisolone was used. So in conclusion, meticulous and comprehensive intensive care is what is required by TBI patients for successful management. It should be multimodal. It should be protocolized, involving hemodynamic support, respiratory care, fluid management, ideals on preventing secondary brain insults, maintaining an adequate cerebral perfusion pressure, and optimizing cerebral oxygenation. So in nutshell, it requires a multidisciplinary approach with the help of neurosurgeon, neurointensivist, physiotherapist, respiratory care physician, so as to provide a holistic approach to the patient, resulting in good recovery and rehabilitation. Thank you.
Thank you, Dr. Sharmishtha. That was definitely a meticulous, comprehensive, truly a masterclass of ICU management of traumatic brain injury. Now I would like to invite Dr. Archana to speak about the landmark trials with regard to traumatic brain injury.
Trying to share my screen.
Yeah, can you see my
Yeah.
slide?
Yeah, Dr. Archana, your slides are visible. You can go ahead.
Yeah. Good evening, everybody. After the discussion of the management, pathophysiology, and treatment of traumatic brain injury, I would like to talk about some landmark trials which were done in traumatic brain injury, which have led to the incorporation of these parameters into the guidelines. So the traumatic brain injury remains a major public health problem, and the TBI trials aim to improve the patient outcome to obtain better understanding of the pathophysiology of the traumatic brain injury through continued research. So these studies were done to target a particular therapy, be it a mechanism which needs to be prevented or introduction of a drug to have a desired effect of the mechanism for treatment. Now, what is a landmark study? These studies have influenced the practice of medicine or surgery in a major way. It was conducted in a large number of patients. It is multicentric in nature and it has a described limitations. I will be dealing with trials on these components of treatment in traumatic brain injuries. Coming to fluid resuscitation, the SAFE study, it was a comparison of albumin and saline for fluid resuscitation in the intensive care unit. This was done on a heterogeneous population in ICU. The post-hoc analysis of the SAFE study in the subgroup of traumatic brain injury, that is a severe traumatic brain injury, was done, and patients were randomized to receive 4% albumin and normal saline. And it showed that the patients treated with 4% albumin, there was a 1.88-fold increased relative risk of death at 24 months compared to the saline treatment group. This led to the recommendation by the European Society of Intensive Care Medicine that the colloids should not be used in treatment of patients with traumatic brain injuries. They stated a limitation that the rate of death from any cause cannot be considered as appropriate outcome measurement. Now, this study was critically studied among by various people, and the shortcomings of this study, which they said, was here the albumin which was used was 4%, which was hypertonic, and it is well aware that hypertonic fluids can cause brain injury by increase in cerebral edema. Hence, this study cannot really tell us whether albumin and normal saline can be used as fluid resuscitation or not. Now, coming to the role of decompressive craniectomy in traumatic brain injury, I'll be mainly talking about two trials, the DECRA and the RESCUE ICP trial. Uh, the decompressive craniectomy in diffuse traumatic brain injury. This was done with patients with diffuse traumatic brain injury and an intracranial pressure of more than 20 mm Hg, 20 mm Hg, which was refractory to first tier therapies to undergo either bifrontotemporal decompressive craniectomy or a standard care. They use a Glasgow outcome scale at 6 months as their primary outcome. Here it was seen that the patient in the craniotomy group, as compared with those in the standard care group, had less time with the intracranial pressures above the treatment thresholds. But these patients had worse scores on the extended Glasgow outcome scale. And they concluded that in adults with severe traumatic brain injury, the bifrontotemporal decompressive craniectomy, though it decreased intracranial pressure and the length of stay in the ICU, was associated with more unfavorable outcome. Some of the limitations which they stated was that the medical and the surgical team were obviously aware of the study group assignment, as uh, the person who underwent like a person undergoes a surgery cannot be blinded by the people studying it. And it is said that one center recruited more than one third of the trial participant, which could have skewed the results. And there were baseline imbalances
in the characteristic, especially the proportion of patients with pupillary reactivity at hospital admission was seen to be more in the decompressive craniectomy group, which might have affected the results. So the critical comments that this study received was that this study contained a small subset of patients with traumatic brain injury, and it did not include mass lesions like EDH or SDH in it. And the choice of the operative technique, that is the bifrontal procedure with the division of the sagittal sinus and the pars cerebri, they said limited the procedural efficacy of lowering the intracranial pressure. And a long accrual time, that is the study was conducted over a period of 10 years, said that over this 10 years there might have been major differences in the treatment evolved. Now, this is another study, the Rescue ICP. This study compared patients with elevated intracranial pressure. Here, the pressure use was more than 25 mmHg, as to in DECRA, it was 20 mmHg, to undergo a decompressive craniectomy or medical care. The primary outcome here also was extended a Glasgow outcome scale at 6 months. The Glasgow outcome scale extended distribution differed between the two groups, which was significant. But it was seen that the surgical patients had a fewer hours than the medical patients with intracranial pressure above 25 mmHg. So they concluded that at 6 months, the decompressive craniectomy in patients with traumatic brain injury and refractory intracranial hypertension resulted in a lower mortality but a higher rates of vegetative state. Here also the limitations was the blinding was not possible, and the patients, there were 10 patients who withdrew consent, and 7 patients were lost for follow-up. And this study did not assess the effectiveness of primary decompressive craniectomy, as the patients in the medical group who did not improve with the standard care underwent decompressive craniectomy, which again might have skewed the results. This study was criticized as most patients underwent a bifrontal craniotomy, and an analysis according to the type of surgery was not done. That is, unilateral versus bilateral decompressive craniectomy as a subgroup analysis was not done. And this trial included children as young as 10 years. And as we are well aware that the outcomes are generally good in school-going children, and hence this age group needs a separate subgroup analysis. Coming to hypothermia in traumatic brain injury, there are various studies in hypothermia, but I'll be talking about 2 studies, the Eurotherm and the Polar study. The Eurotherm study was conducted on adults with an intracranial pressure of more than 20 mmHg, and the patients were randomized to standard care or hypothermia. Here also the primary outcome was Glasgow outcome scale extended at 6 months. And it was seen that in patients with an intracranial pressure of more than 20 mmHg after traumatic brain injury, the therapeutic hypothermia plus standard care to reduce intracranial pressure did not improve the outcomes than compared to the patients with standard care alone. Here, the limitations which they showed, that there was a lack of blinding, due to which the serious adverse events, that is the cardiac instability, reduced cerebral perfusion pressure, bleeding, or the occurrence of ARDS in the control group might have been underreported. Here, the study was critiqued for using an ICP threshold of 20 mmHg, which is not really very high. And here, the target cerebral perfusion pressure was not measured in the protocol. And no adjustment was made for the potential baseline imbalances between the trial groups in mass lesions and secondary insults like hypotension or hypoxemic events. These events were not measured in the 2 groups, which might have skewed the results. Now, coming to the POLAR study, that is the effect of the early and sustained prophylactic hypothermia on neurological outcomes among patients with severe traumatic brain injury. Here, the prophylactic hypothermia targeted was early induction of hypothermia to that is 33 to 37 degrees for at least 72 hours and up to 7 days if the intracranial pressures were elevated, followed by gradual rewarming, and the other group in which normothermia was maintained. The main outcome was Glasgow Coma scale extended at 6 months after the injury. Uh, Here it was seen that the Glasgow outcome scale was worse in patients with hypothermia, and the adverse effects of the hypothermia, that is occurrence of pneumonia and increased intracranial bleeding, was also more in hypothermia group. Hence, they concluded that among the patients with severe traumatic brain injury, prophylactic hypothermia is not warranted. Limitation here again was that there was no blinding done, and the significant number of patients did not reach the target temperature. uh, Ola et al. Revisited the polar RCT study and brought forward a point that a cooling extent was not sufficiently high enough in the hypothermia group. And they say that in the subgroup with high cooling index, the hypothermia was actually found to be beneficial. Now, coming to the limitations of these hypothermia trials was the lack of blinding, the underreporting of the serious adverse effects in the hypothermia group, and the benefits and the harms of other intervention used to reduce the ICP was not assessed in any of these trials. But even then, seeing all these trials, in none of the trials, uh, favorable outcome was seen, and the adverse effect was significantly more in the hypothermia group compared to the normothermia group, and hence hypothermia is not included in any of the guidelines in treatment of traumatic brain injury. Coming to hyperosmolar therapy, we are well aware that the efficacy of mannitol has been studied by many reasonable sized randomized control trials, but now there has been an increase in usage of hypertonic saline. Here, this is a study which compared the usage of hypertonic saline and mannitol to see which reduce the cumulative and daily intracranial pressure burdens after severe traumatic brain injury. And it was seen that the cumulative ICP burden and the percentage of the total number of days where the ICP was more than 25 mmHg was reduced in patients in whom hypertonic saline was used compared to mannitol. And it was also seen that the 2 week mortality rates were also less in the hypertonic saline group than compared to mannitol, but this was not statistically significant. And hence, they concluded that the hypertonic saline given as a bolus therapy was more effective than mannitol in lowering the cumulative daily ICP burdens after severe traumatic brain injury. And they said that the patients in the hypertonic saline group had a significantly lower number of ICU days. The limitations which they quoted was this was a study with a small sample size, and again the other methods used to reduce ICP was not addressed here. uh, so many people who had critical comments on this study said that the hyperosmolar therapy in patients was titrated to effect on the ICP to reduce it less than 25 mmHg, but the osmolar or the volume considerations of the hypertonic saline and mannitol were not used for dosing, and the long term data was not observed in the study. Now coming to the usage of hyperventilation, that is the prolonged hyperventilation in patients with severe head injury. This is a randomized clinical trial done to compare normoventilation to prolonged ventilation with or without the addition of tromethamine. Here it was seen that when hyperventilation was compared to the control, that is normoventilation, the Glasgow outcome scale at 3 months was worse in the hyperventilation group, which was significant in in patients with MOTA score of 4 and 5. Hence, they concluded that the patients with the initial GCS MOTA score of 4 to 5 that were hyperventilated during the first 5 days after the injury had significantly worse outcomes due to reduced cerebral blood flow. And the limitation was the power of the analysis was not sufficient enough. So many studies have critiqued this study, telling that the hyperventilation was used prophylactically here and not prophylactically in this study, and the increase in ICP or increase in ICP was not proven in these studies. Now, coming to the CRASH trial to assess the use of corticosteroids in traumatic brain injury, where patients with head injury with a Glasgow coma scale of 14 or less within 8 hours of injury were randomly allocated to 48-hour infusion of corticosteroid, that is the methylprednisolone, or a placebo. The primary outcome was death within 2 weeks of injury and death or disability at 6 months. Here they saw that the death from all causes within 2 weeks was higher in the group allocated to corticosteroids. So they concluded that the steroids should not be used routinely, whatever the severity of the head injury. This study was critiqued as it was halted in the interim stage, proving the futility of the study, stating that the corticosteroids actually harmed the patients with traumatic brain injury, and this halting in the interim stage may be interim stage may produce results due to the extreme play of the chance. And hyperglycemia, which occurred in the corticosteroid group, may have unblinded the assessors to the allocation of the group. And here, the cause of the death was not determined. So, further theories and explanation of results are limited. And the corticosteroid used in this study was methylprednisolone, and hence it cannot be generalized to all steroids. And more studies may need to be done. Now, coming to the CRASH 3 trial, that is the effect of the tranexamic acid in patients with acute traumatic brain injury. Here, the tranexamic acid was 1 gram of tranexamic acid over 10 minutes was given, followed by 1 gram over 8 hours. Though the result showed no significant differences in the head injury related death within 28 days after tranexamic acid compared to placebo, it was seen in mild to moderate head injury, that is GCS of 9 to 15. It was shown that there was a mortality benefit in these subgroup of patients, and it was seen in these subgroup of patients that there was no increase in the vascular occlusive events. So they concluded that by giving tranexamic acid within 3 hours of injury, the tranexamic acid has shown a mortality benefit in a head injury related death in patients with acute traumatic brain injury with a GCS of 9 to 15. This study was critiqued as 28 days mortalities would miss certain cohorts. That is, many patients were discharged to other hospitals, and a death beyond 28 days, which was not accounted to. And in this study, there was no mention of pre-hospital management. That is the resuscitation measures which was undertaken, and it was not matched in the patients who received either tranexamic acid or a placebo. And they say that the outcome related to the neurological state would have been better in assessing these patients than using a mortality. Coming to the seizure prophylaxis in patients with traumatic brain injuries. This is a randomized double-blind study of phenytoin for the prevention of post-traumatic seizures. Here, an intravenous loading dose was given within 24 hours of injury, and the serum levels of phenytoin were maintained in the therapeutic range of 3 to 6 micromole of free phenytoin per liter. Here they saw that between the drug loading and the day 7, the patients assigned to the phenytoin group had less seizures compared to the patients assigned to placebo. But this effect was not seen beyond day 7. So they concluded that the phenytoin exerts a beneficial effect by reducing seizures only during the first week after severe traumatic head injury. The limitations of this study included that the phenytoin was stopped due to the in many patients due to the occurrence of idiosyncratic reaction, and the placebo group patients received phenytoin if seizure occurred in them, and this might have affected the results. Buer et al. Studied this and critiqued that in this study, the location of the brain contusion was not described, which might play a part in occurrence of seizures, and the type of seizures was not described. Since there has been introduction and increased usage of levetiracetam, this is a study, a prospective multi-center study, which compares levetiracetam with phenytoin for early post-traumatic seizure prophylaxis. Here, patients with blunt traumatic injuries were randomized to either receive phenytoin or levetiracetam. And here it was seen that there was no difference in the seizure rate between the two groups, or adverse drug reactions between the two groups, or mortality between the two groups. So, in this prospective evaluation of early post traumatic seizure prophylaxis, the levetiracetam did not outperform phenytoin, and hence the cost and need for serum monitoring could be a consideration in guiding the choice of prophylactic agent. So hence levetiracetam has still not been included in any of the guidelines. Coming to the intracranial pressure monitoring, BEST-TRIP trial, that is the benchmark evidence from the South American trial in the treatment of intracranial pressure. This was a study done in Argentina, that is in Bolivia and Ecuador, and the patients were randomized into a pressure monitoring group or the imaging or clinical examination group for further treatment. The primary outcome of this group was a composite measure that was based on the performance across 21 measures of functional and cognitive status, which was calculated as a percentile. There was no significant difference between the group in the primary outcome, although the number of days of brain specific treatment, that is administration of hyperosmolar fluid and the use of hyperventilation in the ICU, was higher in the imaging and clinical examination group than in the pressure monitoring group. So in this study, they concluded that for patients with severe traumatic brain injury, the care focused on maintaining monitored intracranial pressure at 20 mmHg or less was not shown to be superior to care based on imaging or clinical examination. This study was critiqued that the pre-hospital resuscitation measures were not included in this, which might have skewed the study. And outcome in patients who underwent craniotomy or craniectomy was not measured separately, and the effects of hyperosmolar agents and hyperventilation was not assessed. Uh, and this study also had an ethical issue, that this study was done in Bolivia and Ecuador, and the investigators were in America, which brought out a question that maybe this study had ethical issue, and hence it was not allowed to conduct in America, and so it was conducted in a third world country, which was easier. And the Cambridge head injury group said that the non-conventional use of a composite measure was uh, not really good, as a more conventional Glasgow outcome scale could have been used to measure the difference. And the Cambridge head injury group also said that this treatment was done on the number of the ICP, and the more emphasis needs to be given on the analysis of the ICP. Now, as we are aware that autoregulation is very important in managing any patient with traumatic brain injury. So this was a study of critical thresholds for cerebrovascular reactivity after traumatic brain injury, where pressure reactive index was used as a tool in brain monitoring of trauma patients. Here, it was seen that in all patients, they found that the pressure reactive index had different thresholds for survival, that is 0.25, and for favorable outcome, that is the value of 0.05. And the threshold of 70 mm Hg for cerebral perfusion pressure and 22 mmHg for ICP were identified for both survival and favorable outcome, which was included in the Brain Trauma Foundation guidelines. And the ICP threshold for favorable outcome was lower in females and in patients older than 55 years. So here the prognostic role of pressure reactive index is confirmed, and the results in the ICP are in line with the current guidelines. However, the lower value in elderly and in the female suggests an increased vulnerability to intracranial hypertension in these groups. Now coming to this is just a summary, and this trial from which the guidelines were taken. So, in conclusion, TBI is a common and a major cause of morbidity and mortality, and the management is focused on preventing the secondary injuries and the maintenance of cerebral perfusion pressure. And hence, the adherence to guidelines and the management algorithms derived by analysis of major trial help to guide a target-driven care and are associated with better survival. Thank you.
Thank you, Dr. Archana, for this exhaustive presentation. And it's always very difficult to go through literature and understand each trial. And I think you have done a commendable job in, making it very simple and giving a comprehensive view of all the available trials in each area. So I would like to take this opportunity to thank all the speakers, Swati ma'am, Dr. Sharmishtha, Dr. Sindhu, for conducting this masterclass truly in a masterful way. On behalf of Neurocritical Care Society of India, we look forward to meeting you in further forums. Thank you very much.